Okay. Welcome, everyone. I see folks are still arriving, and I think we have a pretty large streaming audience today. So welcome those of you who are not in the room with us, but participating online. This is the last of our Population Health Spotlight series devoted to infectious diseases. We are grateful for the sponsor of this series, the Eli Abertin Lectureship Fund. And I want to acknowledge Eli's family, son Alex, wife Leslie, who are here with us, also Dean Emeritus Dr. Marla Gold, who was the dean who created the Lectureship Fund many years ago. Just a few words about Dr. Abertin. He was an internationally renowned infectious disease physician. Marla and I both had the privilege of doing rounds with Eli for several years. He had numerous leadership positions at the Medical College of Pennsylvania and Hahnemann University Hospital, the predecessor institutions of the Drexel University College of Medicine, including interim chair of medicine, associate provost, and associate dean for faculty affairs. He was the president of SHEA, the Society for Healthcare Epidemiology, and was really a renowned infectious disease expert, a voice of calm in times of chaos, and a mentor to myself, to many in this room. And so we are grateful for having worked with him and appreciate this opportunity to honor him. So with that, I'm going to introduce today's speaker, who is Dr. Stanley Plotkin. He will speak to us today on correlates of vaccine-induced immunity. Dr. Stanley Plotkin is an emeritus professor at the University of Pennsylvania. Until 1991, he was professor of pediatrics and microbiology at the University of Pennsylvania, professor of virology at the Worcester Institute, and at the same time, director of infectious diseases and senior physician at the Children's Hospital of Philadelphia. For 7 years subsequently, he was medical and scientific director at Sanofi Pasteur, based in Marne-la-Coquette, outside Paris, and he is now a consultant to vaccine developers and to nonprofit research organizations. Dr. Plotkin is a member of the Institute of Medicine of the National Academy of Sciences and the French Academy of Medicine. His bibliography includes over 900 articles, and he has edited several books, including the textbook Vaccines, which is now in its 8th edition. Dr. Plotkin has received honorary doctoral degrees from the University of Pennsylvania, the University of Rouen, and Complutense University of Madrid. He's also received the French Legion of Honor. Dr. Plotkin developed the rubella vaccine, which is now standard use throughout the world, yes, and I think many youngsters don't appreciate the catastrophe that congenital rubella is and the miracle that a highly safe and effective vaccine is for us as a society. He's also the co-developer of the pentavalent rotavirus vaccine, has worked extensively on the development and application of other vaccines, including anthrax, oral polio, rabies, varicella, and cytomegalovirus. He's really a giant in the world of vaccines. We are thrilled to host him today, and please join me in welcoming Dr. Plotkin.
That work? Well, thank you very much for that introduction. And thank you for coming to hear my talk. I did know Dr. Abertin and I am honored to speak in his honor. And so what I've decided to talk about today, I trust you hear me in the back, is correlates of vaccine-induced immunity. That is, what is it that vaccines do to induce immunity? How do they work, and how do we interpret how they work, which is essential to understanding those vaccines and making new vaccines or improved vaccines. So, oh yes, that's right. Somebody else is going to advance the slides. So let me explain why are correlates of immunity important. Well, Of course, we want to understand immunology, so that's reason number one. But more importantly, it enables the correct choice of the vaccine antigen that you want to use. It permits you to consistently measure potency of a vaccine if you know the correlate. It enables you to determine the susceptibility of an individual or a population if you are able to measure the correlate of immunity. And if an efficacy trial is not feasible or ethical, you can use immunologic data to enable the licensure and use of a vaccine. And lastly, it enables you to bridge from a first generation vaccine to second or later generation vaccines. Next slide. These are references, obviously somewhat egotistical, but if you wish, if anybody wishes, I'll be glad to send you this slide if you want to read further. So definitions are important in this field as well, of course, as others. So what is a correlate of protection? Basically, it is an immune response that is statistically interrelated with protection. So it's really a statistical value, but it comes in different varieties. It can be an absolute correlate, that is to say, a specific level of response, an antibody, for example, that is highly correlated with protection. In other words, a threshold above which a vaccinee is protected. But it also may be a relative correlate, that is, where the level of response is variably correlated with protection. Higher being more protection, but protection may occur with lower values. And there may be more than one correlate, co-correlates, one of two or more factors that correlate with protection in alternative, additive, or synergistic ways. So definitions are important in understanding this field. So first of all, mechanistic correlate of protection. By mechanistic, meaning an immune response that is directly responsible for protection. That's, of course, what you are usually looking for. Next slide. However, there may be non-mechanistic correlates of protection, which are sometimes called surrogates. That is an immune response that substitutes for the true immunologic correlate of protection, which may be unknown or not easily measurable. So these non-mechanistic correlates are tools where you don't have a real mechanistic correlate. So how are correlates determined? There are a variety of ways. One is if you can identify a level of passively administered antibody or maternal antibody that protects, that gives you a correlate. I mean, if you know that a certain amount of let's say, passive antibody protects an infant, that gives you a correlate. But more often, it comes from an analysis of immune responses in protected and unprotected subjects in efficacy trials. And that's one of the reasons one does an efficacy trial, to obtain a correlate of protection. Now, of course, you can also observe vaccine failures, for example, immunosuppressed individuals. If an individual who lacks antibody, but nevertheless is protected by cellular responses, that tells you that cellular responses correlate with protection. Interestingly, and I've certainly used this myself, human challenge studies are an important way of identifying correlates. That is, by using a variety of volunteers in those studies and measuring their immune responses, you may be able to extract from those data the correlate of protection. Now, in the absence of the ability to do human studies, for example, let's say with anthrax, you can use animal challenge studies, including immunodeficient animals, enabling you to determine the correlate of protection. So, what are some of the potential protective immune responses induced by vaccination? Now, I'm not going to go through this slide in detail, but it's just to point out that the immune system has evolved over millennia to be multiple, redundant. And so you have, of course, serum antibody responses, you have mucosal antibody responses, you have both CD4 and CD8 T cells, as well as Th17 and other types of T cells. So the potential immune mechanisms are truly multiple and have evolved, in a sense, to be redundant. Next slide. But as this slide says, even though we know that immune responses are multiple and overlapping, but the idea of a correlate is to select those responses that correlate best with protection. It enables you to make a prediction, and that is the essence of why you want a correlate of protection. Next slide. So now I'm going to define what I call the 10 principles surrounding this area. And the first principle is, if you're trying to identify a correlate, you have to define against what? I mean, are you talking about protection against infection, local infection, or disseminated infection? Are you looking for a correlate against severe disease or mild disease? So again, you have to define what you're looking for. Next. And so here is the example of polio. We know that protection against polio paralysis is due to IgG serum antibodies, because the virus has to pass from the mucosa to the central nervous system. And the presence of antibody prevents that. But protection against infection at the level of the pharynx and the intestine depends on the presence of IgA and IgG antibodies, mucosal antibodies. So this pertains to the difference between oral polio vaccine and inactivated polio vaccine. Next slide. That is before leaving that to point out that the oral polio vaccine induces a mucosal response as well as serum, whereas the inactivated vaccine largely produces serum antibody. So turning to another infection, pneumococcal disease. Now, pneumococci infect the nasopharynx and spread from the nasopharynx. They spread in the bloodstream, and the result is pneumonia. Well, bacteremia itself can certainly be a deadly disease, but pneumonia is one result. Otitis is another result. And nasopharyngeal carriage, just carrying the organism and being able to transmit it, is another possibility. And so when one looks at antibody responses, it turns out that low levels of antibody prevent the bacteria from spreading in the bloodstream. But you need more antibody if bloodstream infection occurs. Nevertheless, you need more antibody to prevent pneumonia and even more antibody to prevent otitis and even more antibody to prevent nasopharyngeal carriage, which is why so many people carry pneumococci and can transmit them even though they themselves may not become ill. Next slide. So the second principle is that the mechanism of protection against infection is not necessarily the same mechanism as recovery from infection. Next slide. And here is the example of measles. If you have less than what is measured as 120 milli-international units of neutralizing antibody, you are susceptible to, clinical regular measles, and of course you seroconvert. If you have intermediate levels, 200 to 1,000 milli-international units, you are still protected against measles, clinical measles, but you can be infected. And 2/3 of people in this category will seroconvert because they've been infected, but they don't get disease. If, on the other hand, you have more than 1,000 milli-international units, you not only are protected against measles, but you're protected against infection. You have no serologic response to exposure. Next slide. However, B-cell deficient humans do recover from measles, whereas T-cell deficient humans suffer serious and fatal measles. And this was demonstrated clearly in monkeys, where monkeys vaccinated with measles, not the live vaccine, but part of a kill vaccine, had low T-cell responses, but they did develop antibodies. So they were protected against rash, but they remained chronically viremic. Whereas if you depleted monkeys of CD8 T cells as well, they had major viremia and serious disease. So this illustrates how different immune responses prevent infection in the case of measles. The third principle is that a large challenge dose can overcome immunity. Next slide. And this can be illustrated again using polio, where using oral polio vaccine as a sort of an artificial challenge, you can expose both oral polio vaccine vaccinated individuals and inactivated so-called Salk vaccinees. And what this shows is that if you use a large enough challenge dose, you can overcome immunity to both vaccines. In the case of the oral vaccine, because you have mucosal immunity, you're better protected. But even with the Salk vaccine, even though you are protected against paralysis, you can be infected with a large challenge dose. Now, we illustrated this in a more quantitative way using cytomegalovirus. Now, cytomegalovirus is ubiquitous and almost everybody in this room, I'm sure, has been infected with CMV. But we actually using or enlisting Catholic priests, we did a study where we challenged individuals who were seronegative to CMV, naturally seropositive, or using a vaccine that we had developed, became seropositive after vaccination. And we challenged them with 10, 100, or 1,000 plaque-forming units of a low passage strain of CMV. Not surprisingly, seronegative individuals could be infected even with 10 plaque-forming units. Naturally seropositive individuals were immune to 10, immune to 100, but they could be infected with 1,000 plaque-forming units of CMV, illustrating that large challenge doses, lots of exposure, can overcome immunity. The vaccinees were in between. They had substantial infection protection, but not entirely. Next slide. The fourth principle is that most current vaccines protect through antibodies. Next slide. And again, I'm not going to go through this slide in detail, but the reason that most vaccines protect against viremia is because they produce viremia or bacteremia, and therefore serum antibodies prevents that from occurring. There are other examples where antibody interferes with mucosal replication, such as influenza, or passage to neurons in the case of rabies. And we'll come back to the case of zoster later. But for bacteria, it's the same issue. That is protecting against bacteremia or toxinemia, so as in the case of diphtheria. Next slide. This slide simply points out a number of infections where simply giving antibody is clearly useful because it neutralizes the organism before it can produce disease, or in the case of diphtheria, before it produces toxin. And the others are more preventing viremia. So the fifth principle is that correlates may be relative. Next slide. And a good example of that is influenza. Now, we take influenza vaccines and we hope that they will produce antibodies against the hemagglutinin, which is on the surface of the virus. And if we're lucky, it does. But this slide shows on the x-axis the amount of antibody induced in a particular study against the influenza hemagglutinin of the challenge virus, which was an H3 influenza virus. And so, of course, the higher levels of antibody are on the right. On the y-axis is the level of protection given by influenza vaccine to the subjects in this study. And what you see here is that when you get to a titer of about 1 to 40, 1 to 50, you have about 50% protection. But as you go up, you have more protection. Okay, but the slide also shows that even people with high levels of antibody can be infected less, but still they may be infected, showing that in some cases, even high levels of antibody are not going to protect. Well, influenza is a complicated story, but this is one reason why improvement of influenza vaccines by adding other components of the virus is a major aim of vaccine developers. Next slide. Another example is pertussis. That is that having antibodies against the pertussis toxin is clearly a correlate of protection, but it's not absolute. As shown in this slide, if you are in a household where pertussis is circulating, you may get severe pertussis if you have levels of antibody lower than 79 units. Whereas if you have, let's say, about twice that, you will be protected against severe disease, but you may get mild disease. Now, if you have really high levels, you are protected not only against disease, but against infection. And that's true for both household and non-household infections, exposures. The sixth principle is that antibodies must be functional. Next slide. And a good example of that is now old because we have better pneumococcal vaccines. But originally we had a pneumococcal vaccine that basically was the capsule, and it produced opsonophagocytic antibodies, but it was not good at doing that in the elderly. Now, of course, I have to be careful here because the elderly start at 60. And what you see on this slide is that individuals in purple, 20 to 45, had good responses to the vaccine. And they were relatively protected, like was shown in coal miners in South Africa. But if you got over that age, 60 and older, your response was poor. And so the vaccine did not protect the elderly. Next slide. This is a similar example with meningococcal polysaccharide vaccine, whereas it was important to produce bactericidal antibody. If you were a child and received the vaccine, you had a very good chance of developing ELISA, that is antibody measured by ELISA. But your protection was poor, as shown in this Canadian study. But that correlated with the fact that children were not producing bactericidal antibody able to kill meningococci. And so their protection was low compared to the 83% protection of adults. Next slide. The seventh principle is more than one factor may protect as co-correlates. Next. This is shown with the nasally administered live influenza vaccine given to children. These groups were not equal in number, but those children who did not develop antibody either in the serum or the nose, not surprisingly, could be infected. At the bottom, those who developed both serum and nasal antibodies had very good protection against influenza. In between were those who developed serum antibody but no nasal antibody, nasal IgA antibody, and those who developed nasal antibody but no serum antibody. And they were in between. They had some protection, but not as good as having both responses. So indicating the synergy, if you will, between mucosal antibody and serum antibody. Next slide. In the case of influenza, we can say that antibodies in the serum correlate with protection, particularly neutralizing antibodies, but stimulation of T cells, in fact, correlate with increases in antibody. But if you are elderly and don't have a good CD8 CTL response to influenza, the chances are that your protection is not going to be good. Next slide. In the case of pertussis, there are many virulence factors in the organism, including the toxin, but also pertactin and fimbrial agglutinogens. And we know that antibodies against any one of those factors reduces risk of disease. And antibodies against multiple factors reduce that risk synergistically. Next slide. But I should mention before going on that antibodies to the toxin protect against disease, but antibodies against other factors are more important, protecting against infection. So the eighth principle, memory may be a correlate. Next slide. And a great example of this is hepatitis B vaccine, because when children get hepatitis B vaccine, often at birth, they develop antibodies, virtually all of them. However, antibodies to the vaccine fade with time. And by 20 years or so, as illustrated on this slide, only about 50% of the vaccinees still have antibody. The control group were the unvaccinated, and they were a third of them developed natural infection. But the main point on this slide is that even though that those individuals, 50% had lost antibody, they had memory responses, B cell responses, that when exposed later in life, induced antibody to reappear and protect them. And so they had 89% protection, even 20 and more years after vaccination at birth. Next slide. So memory B cells could be demonstrated in them by ELISpot despite non-protective serum antibody levels. Next slide. And so the point that I'm making is that effector memory is important in short incubation infections like bacterial infections, whereas central memory is important for long incubation infections such as hepatitis B. Next slide. Ninth principle, T cell responses as correlates. Next. And the example here is taken from cows who do have mycobacterial tuberculosis infections. And in this very clear experiment, cows were given BCG basically, and those who developed T lymphocyte responses, cells that were secreting interferon gamma, were protected when they were challenged with mycobacteria, whereas those who didn't were not protected, indicating clearly the importance of T cells. Next slide. And in the case of the malaria vaccines that are now being used, it has become clear that although antibodies to what's called the circumsporozoite protein are important, it is TNF alpha producing CD4 T cells and CD8 T cells producing interferon that are the best correlates for protection against malaria with the vaccines that we have now. Next slide. So let me now say some words about coronaviruses. SARS-2 virus, as you know, the cause of COVID-19. And this cartoon of the virus points out, as you know, that the spike protein is on the outside. On the inside, you have the nuclear protein, so-called N protein. And there are other proteins on the outside of the virus. Next slide. So how do we measure protection against coronaviruses? What this slide shows is on the x-axis is essentially the extent of antibody response. And on the y-axis is the protective efficacy. And on the upper corner, you see the messenger RNA vaccines and the Novavax vaccine, which give high efficacy, as you know, and which give high antibody responses. As the curve goes down, you see other vaccines that have been used. Adenovirus vaccines killed coronavirus vaccines. And you see the efficacy dropping because the antibody is dropping. So this clearly shows that neutralizing antibody is a correlate of protection against the SARS-2 coronavirus. Next slide. However, protection against clinical symptoms of COVID infection, if it occurs despite the presence of antibodies, is mediated by T cell responses, particularly CD8 T cell responses. Next. This figure shows essentially what happens in a person infected. You have the viral infection on the left, and viral load in the red occurs, of course, after infection. And then you have the production of antibody, but also the production of T cells, as shown in the peak on the left. And as time goes on, of course, the antibody, the viral load disappears, but the T cell response does persist. The antibody eventually fades to an important degree, but the CD8 T cell responses in, let's say, a young person persist. And those T cell responses give at least important protection against disease, if not totally against reinfection. Next slide. And the importance of the CD8 T cell response in this disease has to be appreciated, because if you have good CD8 T cell responses shown on the left panel, those responses give you prolonged protection against serious disease. However, some individuals, particularly the elderly, do not develop good CD8 T cell responses. And indeed, they may even have a sort of an abnormal response, which allows the virus to persist and even to continue to replicate. And at least many workers argue that there are types of abnormal CD8 T cell responses that cause a kind of a persistent pathology in some patients infected with SARS-2. And that persistent pathology is essentially an immune disorder. Next slide. However, a robust response, such as happens in most young people, does combat COVID-19 and establishes a resident memory in the lungs of those patients, which protects them against subsequent serious disease. Next. So the 10th and last principle is about non-mechanistic correlates of protection. Next slide. And a good example of this is the zoster vaccine. As you know, the zoster vaccine is given to the elderly to prevent the recurrence of varicella. And it consists of the GE protein of the virus together with a strong adjuvant. And the efficacy of that vaccine is very high. It essentially stimulates flagging cellular immunity against varicella virus in the elderly. The vaccine does give you an antibody response, which can be used as a non-mechanistic correlate of protection. But the response that really protects you against zoster is a specific CD4 lymphocyte proliferation response measured as more than 5-0. That is what is protective. But measuring that isn't as easy as measuring antibody. Next slide. And so that we use the antibody as a substitute for measuring cellular immunity. I put in this slide, which basically indicates the growth of cellular immunity after vaccination with the zoster vaccine. It actually increases over the first several years after stimulation, giving you increased markers of CD4 cell stimulation. Next slide. So just a word about intestinal pathogens. And this, I would say, is the major area of ignorance in vaccinology. That is how to induce and measure and induce immune responses in the gut, in the pharynx, etc. But fortunately, there are multiple responses that do give some protection. Mucus, just mucus, is a protective factor. Innate immune responses at the level of the mucosa. Mucosal IgA antibody and mucosal IgG antibody, and leakage of serum IgG antibody, as well as probably as T cell responses, although we don't know much about that. Next slide. And I also want to make a remark about rotavirus vaccines, which I worked on a long time ago. But rotavirus is an intestinal pathogen, and the immunity is very complicated. Neutralizing antibodies directed against a couple of specific surface proteins seem to be important. Just giving oral antibody can protect you against rotavirus. So antibody in the intestine is definitely associated with protection. But cellular immunity alone gives you partial heterotypic immunity, particularly CD4 mediated T cell responses. So you can measure anti-rotavirus serum IgA, and it gives you a good idea about protection, but it is not really the mechanistic correlate of protection. If you can measure secretory IgA, that does appear to be a good correlate. Next slide. And just to give influenza vaccines as examples of the complexity of correlates, as I told you before, hemagglutination inhibition is usually used as the correlate of protection, but microneutralization may be better. And antibodies to neuraminidase contribute. Measurement of antibody-dependent cellular cytotoxic antibodies also appear to contribute to the efficacy of influenza vaccine. Mucosal IgA certainly helps, particularly for live attenuated vaccines. And in the elderly, CD8 T cell function is important. So a good example, as I say, of the complexity of correlates. Next. Additional protective mechanisms besides neutralization. Binding antibodies that prevent attachment seem to be important for Ebola. The Th17 responses seem to help for pneumococci and tuberculosis. I mentioned antibody-dependent cellular cytotoxic antibody. In the case of cytomegalovirus, that's definitely important. Stimulation of CD4 T helper cells that secrete cytokines in the case of pertussis. So the immune system is complex. Next slide. And just to mention in passing, the new respiratory syncytial virus vaccines, clearly high levels of neutralizing antibodies protect infants, but we really do need to learn a lot more about the correlates of protection, including cellular immune responses. Next. So my motto is that with respect to correlates, polytheism is preferable to monotheism. I'll let uh, let you sort of think about that. Next slide. The conclusions are that the immune system is redundant and correlates of protection are often multiple. However, almost all current vaccines work through antibodies in serum or on mucosa that block infection or bacteremia, viremia, and thus provide a mechanistic correlate of protection. The functional characteristics of antibodies as well as quantity are important. Next slide. Antibody may be highly correlated with protection or synergistic with other functions. Immune memory is a critical correlate, effector memory for short incubation diseases, central memory for long incubation diseases. Cellular immunity acts to kill or suppress intracellular pathogens and may also synergize with antibodies. And lastly, for some vaccines, we have no true mechanistic correlate of protection, but only useful non-mechanistic correlates for an unknown or unmeasured protective response. Thank you very much. Oh, yes, my last slide shows the spectrum ranging from anthrax, where antibody response alone is important, to zoster, where cellular response alone is important, but everything else is in between. And again, thank you. Told that I'm supposed to answer questions. Oh, oh, well, I'll stand for a while.
We have a lot of kids that are not vaccinated or under vaccinated with the MMR vaccine. Is there concern about rubella?
Am I concerned about it?
Yeah, recurring.
Huh.
I mean, at this point, we don't see a whole lot of it in the US. But if we have
Well,
that
you know,
many kids who aren't vaccinated with the MMR vaccine.
Well, you know, you're giving me the opportunity. Of course, I'm concerned about it. It's terrible. It is an insult to everything I've ever done. But aside from that personal remark, it is a disaster. I mean, it's plainly a disaster. The idea that children are getting measles when it had virtually disappeared from the United States and is, by the way, essentially disappeared from the Western Hemisphere. Well, maybe not fully, but certainly many countries in the Western Hemisphere are doing pretty well suppressing measles. I can tell you from my experience in France and elsewhere that measles has been essentially suppressed in those countries. So this is a tragedy. And you know, I don't have to explain to this audience the reason for it, but this is a public health failure of major proportions. And it can only be prevented by convincing people to vaccinate their children. It will also, interesting is not the right word, but it will also be important to follow what happens in adults who are not vaccinated, because measles is a serious disease. I mean, it's a serious disease in children, but it's an even more serious disease in adults. And so waiting to see the full impact of this outbreak. But it's a tragedy, no matter how you look at it.
Is there any difference in the immunologic response in a patient that had COVID and quote long COVID?
In difference in response to
The individuals that have what's called long COVID, what kind of immunologic response do they have?
yeah, well, that's of course an important question, and one that's has not really been fully explored. One thing that has to be said is that persistence of infection seems to be a lot more common than we thought, even though the symptoms of disease may become mild. So all I can say is that what we need more research in is the mechanisms of persistence of COVID, either the virus itself or antigens that persist somewhere in the body, and that the immune response to those persistent antigens is what is causing the symptoms. But we definitely need a lot more study of that phenomenon, because we really don't have a good way of dealing with long COVID. Although I personally, I would like to see a study done with essentially vaccinating people with long COVID with large amounts of COVID-19 antigen to see if you can suppress what I think is the persistence of the virus somewhere in the body of those individuals. So that's really all I can say about that at the moment.
There's a couple of online questions. One of them is, I believe I heard you say in discussing co-correlates that T cell responses play a larger role in protection for the elderly, but I'm not sure if that was a general principle or specific to the vaccines you were discussing for influenza. Is it specific to each pathogen, or are T cells important in an age-specific way?
I'm not sure I got the first part of it.
So the question is about the importance of T cell responses.
Yeah.
And whether they're important in the elderly in general, or is it pathogen specific?
Oh, well, unfortunately, the elderly do have declining T cell responses. So I think most of the problem lies in that area, that their T cell responses are inferior to what they were at a younger age, and therefore agents are able to persist. As I, was trying to point out, that antibodies work to decrease the amount of virus, but if virus persists, you have to have a good T cell response to kill those last infected cells. And the elderly clearly are not good at that.
I'm going to ask a question about influenza vaccines, dovetailing on this one. There's a lot of interest and hopes around universal influenza vaccines. What are your thoughts about the prospects of those?
Well, that is, of course, an important goal. And my view is this, that we have been using only one of the antigens of influenza virus for our vaccines. And that has, as I pointed out, has given us moderate efficacy at best. And I think the answer is clearly We need influenza vaccines that contain many more antigens of influenza viruses in order to induce both antibodies and T cell responses to suppress influenza. We are not going to control influenza with our current vaccines. That is very clear. And I, um, I really don't fully understand why there hasn't been more work in this direction. So we have a vaccine that, as I pointed out, is only moderately effective.
There's another question online. Why are intramuscular vaccines more popular if oral vaccines confer more immunity and prevent colonization at mucosal sites? Maybe you could talk a bit about the efficacy of oral vaccines and mucosal immunity versus IM vaccines. And
So the question was why
are intramuscular or IM vaccines more common if
oh,
oral vaccines produce mucosal immunity?
well, the trouble is that you cannot always give an oral vaccine unless you have a way of attenuating it. I mean, if you were to give, let's see, what would be a good example? Pertussis vaccine orally, we know what good would that do? You want a response that acts at where the agent causes disease. And that is not always possible with an oral vaccine. And that's why we use parenteral vaccines. They induce antibodies and cellular responses in the blood that can travel everywhere and suppress wherever the agent is going to replicate. For oral pathogens, okay, you can imagine stimulating responses at the level of the mouth or the gut. But for many diseases, that's not going to work. So, I'm all for more oral vaccines, but only where the pathology can be suppressed by the immune responses that occur at the level of the gut alone. If that's not the case, you need immune responses that are systemic. And if you can have an oral vaccine that replicates sufficiently, you can get those systemic responses. But if you don't have, a lot of replication in the gut, you're not going to get an immune response that is potentially effective.
Thank you. So I'm wondering about downstream clinical diseases as correlates of immunity. So for example, HPV vaccine, downstream, the reduction in cervical cancer has been astounding. And more recently, actually in the last couple of weeks, there's some elegant data on zoster vaccination reducing the onset of dementia among elderly. That's very, very tantalizing. So could you comment on that, these sort of downstream clinical impacts from attacking a virus?
As far as the zoster vaccine is concerned, it's a very interesting finding. Of course, needless to say, I've had zoster vaccine myself, but it's an interesting finding. But it's not obvious what the reason is. It may be that simply the people who take the zoster vaccine are smarter to begin with. But I can't think offhand of a reason unless the vaccine is actually suppressing what varicella virus does in the brain as well as on the skin. Now that could be an explanation, but that's going to require a lot of investigation to prove that point. I'm sorry, and the first part of your question was? Oh, yeah. So in the case of the HPV vaccine, there we know a lot. Essentially, what happens when you take the HPV vaccine is that there are both antibody and cellular responses that occur to the vaccine. And so the antibody responses can act to prevent you from essentially from getting HPV, and therefore the long-term results. And the cellular responses can also suppress the virus if it does infect, and therefore suppress the effects of the virus, which of course include cancer. So for the HPV, I think it's clear why the vaccine works. I just, by coincidence, I just wrote a letter for the inventors to get a prize, the inventors of the HPV vaccine at NIH. But I mean, that was a critical vaccine discovery, that you could prevent the late effects of an infection that is ubiquitous, but in some people eventually causes transformation of cells to cancer. So really an important step.
Other questions? There's one more from the online audience. It's about updated COVID-19 vaccines. Can we expect any in the fall? Will they be accessible for people age 60? The writer is concerned about current federal government cuts and the position on vaccines in general. What do you think's coming along in terms of COVID-19 vaccines? Will there be a new generation?
Sorry, say again?
Is there going to be an updated COVID-19 vaccines in the fall?
Oh, yeah. Well, of course, COVID-19 vaccines have become political. So there are those who will refuse any more. Basically, my view would be that COVID-19 is going to be like influenza. It's not going to go away. There's no reason for it to go away. It continues to mutate to some degree. So it's just going to continue like other viral infections. And what we can do is protect against the severe manifestations. Until we know better how to prevent mucosal infections like COVID-19, all that we can do is to prevent the complications that occur after infection. So I guess what I see is COVID, like influenza, will be a yearly booster situation, and that we will have to continue to be immunized as long as the virus sticks around and continues to mutate like influenza. Of course, well, I obviously could be wrong. Perhaps the virus will disappear tomorrow, but I don't believe in magic. And so I think likely we will have to continue vaccinating against it so that you don't get severe COVID, even if you get a mild infection. That's certainly for whatever it's worth. That's certainly what I'm doing. I mean, I just get a dose every fall and hope for the best.
Other questions? I think that's our last online question.
I'd like to return to something we were discussing at lunch today, and that is, what recommendations do you have for us in public health when there's so much hostility against our science right now, against your science, your career?
Well, I'll give you the answer I gave you at lunch. As an ex-pediatrician, I have no faith in adults. Adults, by the time they become adults, they have learned all kinds of nonsense, and they are not going to abandon them. But children are different. Children are intelligent, they don't have preconceptions, and they're ready to learn. So my answer is that education about health and vaccines has to start in grade school, because that's when children are open to learning. And I mean, you may not be teaching about relativity in that age group, but you can teach them a lot, and particularly about how to be open to knowledge. And if you can establish that in children, I think you have solved the long-term problem that they believe, to teach them to believe in evidence rather than opinion.
Other questions? Well, thank you very much, Dr. Plotkin. We have a reception. Please join us in the lobby.